dysphagia symptom by pharyngeal high-resolution manometry and fiberoptic endoscopic evaluation. Dysphagia was included among the core symptoms of Parkinson by James Parkinson himself, who named the disease in 1817, as over 80% of Parkinson's disease patients present dysphagia at some point during the course of the disease. And dysphagia in Parkinson is associated with a decreased quality of life, as it is associated with depression, malnutrition, dehydration, and the most worrisome of one of these, that is subingestive pneumonia, that is one of the major causes of death in Parkinson's disease. The pathophysiology of dysphagia in Parkinson is not fully clear, as there are possible alteration of both the central and peripheral neural control of swallowing. Something that is to be noted is that dysphagia in Parkinson arises in advanced stages, and there is a sort of discrepancy between the level of dysphagia and the level of neurodegeneration, possibly due to the fact that in early stages, the system, which is a dynamic system of swallowing, actually does a cortical compensation that allows in the early stages not to have as many dysphagia symptoms, while in advanced stages, as the disease progresses, the dysphagia symptoms start to arise. Looking at the neuromuscular junction, we see a number of histological, immunohistological alteration, as there are deposits of alpha-synuclein in peripheral nerve fibers and in the brainstem, but also alteration of the muscle itself, of the myosin heavy chains. And there is an increase in low-speed fibers, type 1 fibers, and a decrease in high-speed fibers, type 2 fibers. And in swallowing, we need actually fastly reacting fibers like high-speed fibers, and low-speed fibers creates a decrease in strength and speed of muscle contraction, and increased rigidity of the muscular structures. And due to a sort of continuous denervation and reinnervation of the muscles, we have histologically atrophy, fibrosis, and muscle fiber grouping, which in a study by Langmore in 2003 was increased in dysphagic patients with Parkinson than non-dysphagic Parkinson patients. To look at the dysphagia, the first exam that we use is fiberendoscopic evaluation of swallowing, which is the most used method of evaluation clinically. It's the gold standard. It is easy, cost-effective, repeatable, and it can be performed at the bedside of the patient, and allows for a detailed analysis, especially of the pharyngeal swallowing phase. But there is a negative side, that fiberendoscopic evaluation of swallowing is a qualitative exam. So it doesn't allow us to quantify the level of residues or of dysphagia, but allow us to give a qualitative evaluation of the symptoms. And it provides info on premature spillage, post-swallowing residues, or penetration and aspiration. Another technique that is the main goal of our presentation is to look at what pharyngeal high-resolution manometry can do. And pharyngeal high-resolution manometry is a technique that allows us to quantify the biomechanical effort of muscles in the pharyngeal tract. So it's a quantitative study. The side effects is that it is costly, and at least in Italy, it is poorly diffused. So the goals of the study are to evaluate dysphagia in Parkinson's disease by FIS and pharyngeal high-resolution manometry by comparing the information provided by these two exams in the same patients and in Parkinson patients compared to control. So we had 20 patients with Parkinson's disease, 12 males and 8 females. All these patients were in a non-state, so they took the morning medication for Parkinson. Their disease was clinically staged by the most famous classification staging of Parkinson, that is the Hoehn-Yahr classification. And we excluded patients with other diseases that may affect swallowing, like head and neck cancer or other neurodegenerative diseases or dementia. Then we have 20 control that were matched for sex and age, and were elderly patient mainly, but not Parkinson patients. And we could by pharyngeal high resolution manometry, we were able to describe the muscular function of various pharyngeal sections, which are the velopharynx, the tongue base, the hypopharynx, and the upper esophageal sphincter. Regarding fibroendoscopic evaluation of swallowing, we performed it by flexible endoscopy with administration of boluses of different texture, and we chose which boluses to administer according to the patient's history of dysphagia. Usually we had a semi-liquid bolus made by fruit pulp, and then we have the jam. We had solid boluses made of crackers, and then we had water and methylene blue. No local anesthetics were used on the pharyngeal tract, not to impair the sensibility that is fundamental for swallowing. Once the food was administered, the patient was instructed to swallow only once instructed to highlight premature spillage. We used to score these exam a quantitative score, that is the pooling score that our same group validated in 2008 and 2014. And we evaluated premature spillage, penetration aspiration, and post-swallowing residues were evaluated based on site, extent, and if the patient was able to clear them after multiple acts. Considering the whole exam, dysphagia was graded as severe, moderate, or absent. And this is a FEES evaluation of a typical Parkinson patient. So you can see in the rhinopharynx fasciculation of and reduced elevation of the velum of the velopharynx. And then going down, you can see chordal hypertrophy and incomplete glottic closure that is typical of hypophonia in Parkinson. Administering semi-solid liquid, you can see post-swallowing residues with residues that are deposited on the laryngeal face of the epiglottis. You can also see in the region of the upper esophageal sphincter an accumulation, a residue. With a soft solid bolus, you see that this situation is worsened, if possible. And with the liquid bolus, due to a delayed in the swallowing phase, you can see an accumulation of liquids that spill onto the glottal plane with a high risk of aspiration and penetration. Regarding pharyngeal high-resolution manometry, we were able to see the pressure exerted by different velopharyngeal structures with accurate temporal resolution. And I remember to you that these structures are the velopharynx, the tongue base, the hypopharynx, and the cricopharyngeal muscle. That is the main muscle of the upper esophageal sphincter. At first, a catheter was introduced transnasally. It is a 4 millimeter catheter with 36 sensors at intervals of 10 centimeters. So first it was introduced up to the stomach, and it was followed as protocol by a 5-minute accommodation time. And then we performed the basal measurements of the whole pharyngo, but also esophageal tract. Then we made the patient swallow 10 milliliters of water in a supine position. As a third step, the patient was put in a sitting position and the catheter was retracted. And then we placed the sensor on the pharyngeal structures to identify the regions of interest that we were looking for. And then we made the patient swallow boluses of liquid, semi-solid, and solids consistently. And for each consistency or texture, we measure the maximal pressure exerted, the mean basal pressure, and then we have, looking at the wave shape, pre-swallowing pressure, a pressure measured during swallowing, and then we have a post-swallowing pressure. And it's important to highlight that this measurement was carried on the same morning as the FEES evaluation, as to have the two exams as close as possible. So this is the graph of pharyngeal high resolution manometry that we obtain. And you can see the different areas that we look for: the velopharynx, the tongue base, the upper esophageal sphincter, with a relaxation phase of cricopharyngeus during swallowing. And then the cricopharyngeus takes again the basal pressure that he has post-swallowing. And you can see in different colors also the pressures exerted by the different areas. Looking at the bedside examination, all patients of Parkinson patients had adequate head and trunk postures and the adequate respiratory state at rest. But all patients had a history of dysphagia with a mean duration of 26 months. Looking at symptoms, voluntary cough was effective in 17 patients, but partially effective in 3 of them. And other symptoms that we recorded were tongue tremor, a decrease in protrusion, especially of the lips and tongue, a decrease in counter resistance, and a decreased amplitude of tongue movements that were present in all patients. Looking at stages of Parkinson's disease, as I said before, dysphagia arises especially in advanced stages of disease. So most patients were at stage 3 or 4, but 2 and 5 were at stage 1 or 2. Looking at FIS results, you see that solid boluses exerted the worst effect. So dysphagia was higher for solids and lower for liquids, as expected. FIS results did not correlate with disease stage or sex, but they did correlate with duration of dysphagia symptoms and with age, with what we know is presbyphagia. And looking at high resolution pharyngeal manometry, we saw that looking at the maximum pressure that could be exerted, there was a significantly decrease in all Parkinson patients with a significancy value, regardless of consistency in the maximal pressure that could be exerted. The greatest deficit in maximal pressure was the tongue base that was decreased in function in 66% of Parkinson's disease patients than controls. But there was also a significant decrease in the velopharynx and in the cricopharyngeus. And then looking at the mean values in looking at a temporal scale, so pre-swallowing, during swallowing, and post-swallowing values, we saw, and this is, we see that it's typical of Parkinson's disease, an increase in the pressure exerted by the cricopharyngeus, both in the basal tone, so pre-swallowing, but this difference with with controls increases significantly during the swallowing phase. So we were able to see these changes at pharyngeal high resolution manometry, not only in the patients that were at FIS dysphagic for boluses, but in all Parkinson's disease patients. So pharyngeal high resolution manometry is able to detect also subclinical changes in early stages of disease. Looking at tongue maze, we see that at the maximal pressure that can be exerted has a significant deficit in comparison to control. At rest, we have anyway an hypertonus, which is not intuitive, but that's the state where tongue base is. And when swallowing, we have a decrease in propulsive push. The cricopharyngeus, at rest, we have a basal hypertonus, and this hypertonus is increased a lot during swallowing. So there is a decreased relaxation where hypertonus persists, and the difference with controls becomes even bigger. So comparing these two exams, we see that the values of pharyngeal high resolution manometry are altered in all Parkinson patients, both dysphagic and non-dysphagic. The pooling score that we used to evaluate fiber endoscopic evaluation of swallowing was not in concordance between FIS and pharyngeal high resolution manometry, meaning that maximal pressure and mean pressure did not depend neither on site nor on type of boluses. The duration of symptoms correlated with FIS results, with a worsening of dysphagia if dysphagia symptoms persisted longer than 36 months, but were not correlated with pharyngeal high resolution manometry. Looking at premature spillage, we see a concordance between FIS and pharyngeal high resolution manometry, with premature spillage being correlated with a decrease in maximal pressure exerted by the velopharynx. And when we look at age, if the patient is older than 17 years of age, FEES and pharyngeal high-resolution manometry provide worse results. In conclusions, pharyngeal high-resolution manometry allows a biomechanical quantification of dysphagia severity. That is something that fibroendoscopic evaluation of swallowing cannot provide. This exam is useful for defining pathophysiology of Parkinson's disease that, as I said at the start of this presentation, is not exactly clear yet, and confirms the hypothesis that in Parkinson, both peripheral and central neuromuscular mechanisms happen. And we highlight also the important role of tongue base and the cricopharyngeus, the tongue base being weaker and the cricopharyngeus being more contracted, also both in the basal and in the relaxation phase that should follow the pharyngeal phase of swallowing. And this exam is especially useful in early subclinical stages of disease, as it was able to record differences in patients that were clinically silent at fiber endoscopic evaluation of swallowing. The negative points is that it's high, it's costly, it is not widely used, at least in Italy. And also it cannot provide identification of residual boluses, because residual boluses did not produce changes in pressure, but this can be solved by coupled pharyngeal high resolution manometry with bioelectrical impedance sensors. So FEES remains the first level diagnostic gold standard, as it is easy to perform and highly specific, but we highlight the importance of pharyngeal high resolution manometry for a better description, a quantitative description of dysphagia symptoms in Parkinson. Thank you for listening.
Thank you, Dr. Silvia. Excellent presentation. Hope all the participants must have benefited by your views and may be helpful in their practice and may get a new idea about